I'm going to call the meeting to order and ask everyone to rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Welcome, everyone. Dee, would you please take the roll?
Director Wallace.
Present.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Eben.
Present.
Director Danielson.
Okay, Nancy?
Okay, I'd like to introduce our speaker this evening. Her name is Catherine Mongovin. She's the Director of Quality Solutions at Healthgrades. She works with numerous hospital clients to provide marketing and quality improvement strategies and insights. She has significant healthcare and consulting experience with expertise in market research, analytics, and improving healthcare marketing strategies. She also holds a Six Sigma Black Belt for process improvement. She holds an MBA from the University of Connecticut in market research and venture consulting and a BS from Michigan State University. With that, I'd like Catherine to come to the podium.
I'm a little shorter than your typical speaker, I think. Well, thank you so much for that kind introduction, and thank you for inviting us to celebrate some extraordinary achievements for Washington Hospital this year in 2018. Just a little bit about Healthgrades. We'll talk about who we are and what we do, as well as our methodology, and then, of course, deliver some great news to the team here at Washington Hospital Healthcare System. At our core, Healthgrades seeks to empower patients with key information on hospital quality and support hospital and physician efforts to improve quality outcomes for patients. Healthgrades is the #1 site where consumers search, research, and verify physicians and hospitals. Each and every year, 360 million of the 480 million consumers seeking information online about providers do so on healthgrades.com. So what do we do? Healthgrades looks at clinical outcomes. So we look at mortality and complication rates only for our ratings. We independently analyze each and every short-term acute care hospital in the nation, nearly 5,000 in all. Hospitals may not opt in or opt out. If you take Medicare patients, we rate you. So we use 3 years of Medicare patient data, fiscal years 2016, 15, and 14. We use a statistical model that compares the actual outcome, what happened to folks when they came through your doors and sought care, to a predicted performance for these specific patient outcomes. Again, looking at mortality and complication rates. We do risk adjust for the acuity of the folks who come through your doors, and our star ratings reflect, as expected, outcomes statistically significantly worse than expected with a 1-star, and with a 5-star, outcome statistically significantly better than expected. So it is our pleasure to announce that Washington Hospital this year is one of America's 100 best hospitals. Congratulations. It's a wonderful achievement. What does this mean? It means that Washington Hospital is among the top 2% of all hospitals in the nation for overall clinical excellence. And this distinction, to be eligible for the America's 100 Best distinction, you must be in the top 5% for at least 5 years. So you've been in the top 5% for 5 years, and this year you're among the top 2%. Wow. Well done. So it's one of only 20 hospitals in the state of California to receive this distinction, and one of 3 in Alameda County. Washington Hospital is one of 15 hospitals in the Bay Area to receive the Distinguished Hospital Award for Clinical Excellence. And you'll notice this is where you're at that 5 years in a row, 2014 through 2018. And this is the distinction that puts you among the top 5% of all hospitals in the nation. And Washington Hospital is the only hospital in the Bay Area to be one of Healthgrades' America's 100 Best Hospitals in the nation for joint replacement for a 7th consecutive year. Wow, your joint program is just doing wonderful. And as we continue those accolades, Washington is the only hospital in the Bay Area to receive the Joint Replacement Excellence Award for 12 consecutive years, and one of only 3 hospitals in the entire state of California to have that distinction for that many years. And again, the only hospital in the Bay Area to receive the Orthopedic Surgery Excellence for 5 consecutive years. So well done to the orthopedics team. Washington Hospital is one of 4 hospitals in the Bay Area to, in 2018, be named one of America's 100 Best for orthopedic surgery, and one of 3 to receive both the America's 100 Best Hospitals distinction and the America's 100 Best for orthopedic surgery. Well done, team here. And just so all of you are aware, that America's 100 Best Hospital distinction, if every hospital in America performed at the level that's of care being performed here and at the other recipient hospitals, over 162,000 lives could have potentially been saved. Think about that number. It's a lot of folks going home to their families. So well done for all the extraordinary care being provided here. So a number of other distinctions: 5-star recipients in heart attack, total knee replacement, total hip replacement, treatment of pneumonia, as well as treatment of sepsis. So a number of these distinctions are long-term distinctions, and we tip our hats to the great work being done by a number of teams here at Washington. And as we look, we see some hospital-wide distinctions, again, that America's 100 Best, as well as the Distinguished Hospital Award, cardiac, orthopedics, pulmonary, and of course, critical care distinctions. As we look at the overall clinical quality trend, you'll notice this is, you guys, this year in 2018, well above that top 5% in America line. And if we drew this line correctly, it would in fact continually be rising, because hospitals like Washington keep moving that bar higher and higher. So an extraordinary amount of work goes into that, and our hats off to that great work being done here. There were no 1-star ratings in 2018, and again, that's extraordinary. So as we look at some regional, so those are supposed to be stars, not H's. I apologize. So the H's are actually stars. So again, Washington Hospital up there in the salmon color, the case volume, the actual rate of complications, and the predicted rate of complications for total knee replacement. You all are head and shoulders above a number of hospitals as far as volume goes in your area. You have one of the lowest actual rates of complications, and your top complication, we saw only 1 case in 2016, so some extraordinary work being done with the joint team. As we look at hip replacement, again, the lowest actual rate of complications on this table, showing some of your competitors, and only 8 patients with complications over the 3-year period. You guys are doing something great. I've got to tell you, if I ever need a hip or knee replaced, I'm coming. As we look at heart attack, again, another 5-star performance with one of the lowest actual rates of in-hospital mortality among your competitors in the Bay Area. And sepsis is another area we wanted to point out where we saw the actual rate of mortality decline over 6% over the 3-year period. So again, our hats off to the great work being done in your critical care unit. So on behalf of Healthgrades, it's a real honor to be here to celebrate your distinctions with you. Nancy, if you'd like to come up with the Washington team, we'd love to take a photo, present you with the America's 100 Best Hospitals Achievement.
Yeah.
Come on, you guys. Please. Yeah. Need the board front and center. Now I'd like to ask all the employees of Washington that are here to come and join us. Please come join us. They're going to have to group us so that we can all get in the photo. We need some direction here. Jeannie, would you please come too? You're as much a part of this as we are. Come on, the service lead is an important part of what we do. You may not sit out. You must come.
No. We stand behind our employees.
No, Jeannie.
I don't know how we're going to do that.
Lisa should definitely, Lisa them should be. Yes.
We need the stool. He wants to try to get in there.
That's what I always say. I am tall. You and I are tall.
We might have to stay.
We'll stay.
Can't see through, can't see you.
I can see Shmi.
Thank you. Thank you very much.
Sure.
This is wonderful. Absolutely wonderful. Thank you so much.
It is such a pleasure. Congratulations to all of you for the extraordinary work that you've done to put yourself among the top 2%.
Oh, very proud. Thank you.
It's our pleasure.
Oh, you do?
Well, that was fun.
It was fun.
Congratulations, Nancy.
Congratulations
Everyone.
to all of us.
Yes, congratulations, everyone.
And this is something that we all do together. No one person is responsible.
That's true. That's true. Thank you.
Everybody can take credit for this.
Sure.
Okay.
Okay, we are now going to consider the minutes from the February 14th, 26th, and 28th meetings. Can I have a motion for approval, please?
So moved.
Second.
Dee?
Director Wallace,
Aye?
Director Stewart,
Aye.
Director Eben,
Aye.
Director Nicholson,
Aye.
Director Danielson.
Motion's approved. Okay, we're going to now move to oral communications. Any oral communications tonight? Seeing-
none.
There are none. Okay. Any written other than the medical report? None? Okay, Dr. Brooks, hi. Go ahead.
Hi. Okay, so the medical staff action items for this meeting. For new applicants, Dr. Vishal Banthia in ENT, Dr. Huan Ha, in Hematology Oncology Medicine, Dr. Tai Hong T. Tran, a nurse practitioner in radiology, Alpa Vora, a physician in internal medicine, and Christopher Voskopoulos, a critical care intensivist. Temporary privileges while the application is waiting for board approval: Vishal Banthia, Juan Ha, Tai Hong Tran, Alpa Vora, and Christopher Voskopoulos. 2-year reappointments: Mark Avon in urology, Dr. Omid Azizarad, an intensivist, Stephen DeGallen, cardiology, Rodora Dela Cruz, pediatrics, Shirley Leong, pediatrics, Robert Miller, physical medicine and rehab, Dr. Amy Cecilia Mogul, intensivist, Dr. Trong No, OBGYN, Dr. Kashmira Ragi Singh, internal medicine, Dr. David Tay, nephrology, and Dr. Timothy Choi in cardiology. 1-year reappointment applicants: Dr. Bruce Lin in interventional radiology, Doctor of dental surgery, Dr. Dale Minkin in dental surgery. Transfer in staff category: Dr. Sumaira Ahmed in internal medicine and Dr. Anil Nair, anesthesiology. Completion of proctoring and advancement in staff category, Dr. Sumaira Ahmed, Internal Medicine. Completion of proctoring prior to eligibility for advancement in staff category, Dr. Jessica Also From in neonatology, Dr. Daniel Kennedy, an intensivist, and Dr. Doris Nguyen, an internal medicine hospitalist. New privilege requests, Dr. Ralph Koo, emergency medicine, requesting deep sedation privileges. Dr. Huey Fan, pediatrics, requesting CCU level 1 privileges. Dr. Kurt Wozniak, cardiothoracic surgery, requesting CCU level 1, 2, and 3 privileges. The following physicians have deleted privileges. Dr. Omid Azizarad deleted privileges as listed as an intensivist, and Dr. Shirley Leong deleted privileges as listed in pediatrics. Withdrawal of, and Dr. Amy Cecilia Mogul, intensivist, with withdrawal of core privileges in anesthesiology. Withdrawal of application, Dr. Apram Basra in emergency medicine withdrew his application. The following physicians have resigned. Dr. Leslie Chan in family medicine, Dr. Munir John Mohammed in cardiology, Dr. Bijal Patel in infectious disease, Dr. Gautam Prasad in radiation oncology, Dr. Lois Vanderhagen in internal medicine. Physician assistant Abigail Getz also is no longer working at Washington Hospital.
Okay, well, thank you. May I have a motion for approval of the credentialing action items?
Mr. President, I move for approval of the credentialing action items as presented by Dr. Albert Brooks.
Thank you. May I have a second?
Second.
Thank you. Dee?
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Eapen.
Aye.
Director Danielson.
Okay, the motion is approved. Jeannie, hi. Service League report, please.
Yes. Good evening. New board came on last month in February. Thank you for those that were able to attend. I took our new and second VP down to the volunteer conference in Newport Beach so they could experience what it's like to be among hundreds of passionate volunteers. In California, there's 366 CHA member hospitals, and in those 366, there's 100,000 volunteers with their feet on the floor. Yeah. And so you get hundreds of them in a room, and there is a buzz. And we just ignore what our mothers taught us, and we talk to strangers. What's going on in your hospitals? What's working? What's not working? What changes? What challenges do you have? And it's a wonderful time of just being able to collaborate and share. They're wonderful speakers. I think the most compelling was an anesthesiologist from New Zealand who came for the 3 days with his wife just for that conference because he had something to share. He doesn't answer every request. If you like TED Talks, look up Dr. Robin Youngson. He is an incredible speaker, and he was happy in just being an anesthesiologist. He was a leader in his hospital, and then his teenage daughter had a horrific traffic accident, a car accident, and she was in halo traction for 100 days. And the things that he learned being in that role and being out of control taught him so much that, and he's been now speaking and practicing, but New Zealand has offered him many awards because of the way that he's revolutionizing healthcare. He's putting the care back in the healthcare. He wrote a book called Time to Care, and it's time to care. It's take time to care. What his findings are based on are neuroscience studies. Normally when I hear these things, I think it's touchy-feely, mumbo-jumbo, just care for your patients and they'll get better. But his actually show the changes in the brain when your patients feel like their anxieties and all their feelings are being addressed and they're not being ignored. They heal faster, they need less pain medication, they're in the hospital less, and they're finding this and they're documenting it. And one of the greatest benefits is that those that are actually trying it are finding they're loving their jobs more. because they're reminded of why they got into what they're doing in the first place, no matter what kind of clinician you are. And so he came to share that and just challenge us to think of times when people have taken that extra minute to say, what is it that's really worrying you? So that was one of the great takeaways. So Dr. Robin Youngson, look him up.
Okay, I will look for him on TED.
Yeah, why?
There's a study just out of the University of Colorado that looks at patients' brain waves when they're holding the hand of a loved one. And that simple contact shows that pain, medication requirements go way down. The brain waves alter significantly. And the patient is exactly as you've described, a great deal less anxious and more comfortable. They haven't tied it in this particular study to healing, although they expect that it absolutely will. And I've got a copy of that study. I'll get it for you.
Wonderful.
We're looking at it in our patient experience program. And in the new hospital building, there will be day beds in every room, including in critical care. And a family member will be able to stay with the patient. And I think the touch of a loved family member can make all the difference in the world to a patient. I absolutely believe it.
I totally agree. And
I'm so glad you told us about this.
next month, I want to tell you some of the things that the volunteers are doing to kind of fill in that gap for the busy staff.
Oh,
So
that's
stay tuned.
wonderful. I can't wait. It's going to be wonderful. Thank you.
Thank you very much, Jeannie.
Sure,
Thank you.
my pleasure.
Dr. Brooks.
Yes, I'm happy to tell you that Washington Hospital's medical staff continues to grow. Currently, as of March, we'll have 340 active physicians, 3 administrative, and I'm proud to be one of those administrative physicians in a top 100 hospital. I have to comment that I was walking down the street in Oakland recently, and someone said, "I read about your hospital, and I hear it's one of the best hospitals in the country." And I said, "Absolutely." And I'm just proud. I just think it's fantastic. So we now have 17 allied health doctors. We have 95 ambulatory, 7 consulting, 24 courtesy, provisional active 78, provisional allied health 15, provisional courtesy 4, temporary privileges 5, and 1 withdrawn, to bring us to a grand total of 589 physicians and allieds. So we're getting close to 600, and we have 12 new applicants next month.
Oh, wow.
So I think we're going over it.
Okay.
'Cause if we
All right. Well, thank you, Dr. Brooks.
Sure.
Okay, Nancy.
We'll start with the tape of the hospital calendar, please.
Past health promotions and outreach events. During the month of February, Lucy Hernandez, Community Outreach Project Manager, provided 17 hand hygiene presentations for students at Vallejo Mill Elementary School in Fremont, Schilling Elementary School in Newark, and Alvarado and Searles Elementary School in Union City. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 419 students participated. On Thursday, February 15th, as part of the Women Empowering Women series, Dr. Victoria Leaphart, gynecologist, presented Women's Heart Health. 13 people attended. On Wednesday, February 20th, Dr. Catherine Dow, cardiologist, presented Heart Disease in Women. 51 people attended. Washington Hospital continued the 8-part mental health education series with expert speakers on various areas of mental health. The second seminar on February 22nd featured Dr. Seema Sehgal, Psychiatry and Behavioral Sciences, who presented anxiety disorders. 93 people attended. The third seminar on March 8th, Dr. Seema Sehgal presented Understanding Mood Disorders. 65 people attended. On Friday, February 23rd, Washington Sports Medicine provided athletic trainers and hosted a first aid booth at the Special Olympics basketball tournament at Newark Memorial High School. 340 local athletes participated in this event. On Saturday, February 24th, Prince of Peace and Our Savior Lutheran Church in Fremont hosted Healthy Living in a Stress-Filled World. Lucy Hernandez provided blood pressure screenings, and Luann Sadweste, RN, conducted risk assessments for type 2 diabetes. More than 100 people visited the health information booth, of which 32 were screened. On Tuesday, March 13th, Dr. Stacy Berry, obstetrician and gynecologist, and Dr. Mary Maish, thoracic surgeon, presented solutions for weight management and surgery options for treatment of obesity. 16 people attended. Upcoming health promotions and community outreach events. On Thursday, March 15th, from 6 to 8 p.m. at the Washington Township Medical Foundation Newark Clinic Conference Room, Dr. Tam Nguyen, Family Medicine, will present Obesity, Understand the Causes, Consequences, and Prevention. This seminar will also be presented at the Nakamura Clinic Conference Room in Union City on Wednesday, March 28th from 6 to 8 p.m. Also on Thursday, March 15th from 7 to 8:30 p.m. as part of the Women Empowering Women series, Dr. Victoria Leapart will present Prioritizing Your Life. It's Time to Get Organized. On Thursday, March 22nd, from 6:30 to 8 p.m., as part of the Mental Health Education Series, Dr. Seema Sehgal will present Understanding Psychotic Disorders. Other upcoming seminars include The Link Between Substance Abuse and Mental Health Disorders, presented by Carmen Masson, Ph.D., UCSF. April 19th, When Depression Occurs with Other Medical Conditions, presented by Simone Madan, Ph.D., UCSF. May 3rd, Mental Wellness, presented by Michelle Williams-Smith, Senior Family Advocate, Family Education and Resource Center, and Dr. Victoria Leapart. May 17th, Family Support, Caring for Those with Mental Health Disorders, presented by Michelle Williams-Smith. On Saturday, March 17th, from 10 a.m. to 1 p.m., Washington Hospital will host Stroke Awareness Day. This event screens community members for carotid artery blockage, atrial fibrillation, in addition to cholesterol, glucose, and blood pressure screenings. The event also includes stroke education, particularly learning the signs of a stroke and the importance of calling 911. It is vital for our community to learn every second wasted is heart or brain tissue loss, increasing the risk for death or disability. By calling 911, emergency providers are equipped with knowledge and resources to begin treatment needed in the shortest amount of time. This event is co-sponsored by Fremont Bank Foundation. Appointments are available for screenings at this event. To register, call 800-963-7070. On Tuesday, March 20th, from 6 to 8 p.m. at the Washington Township Medical Foundation Newark Clinic Conference Room, Christy Caracappa, Health Insurance Information Service Coordinator, will present New to Medicare, What You Need to Know. This seminar will also be presented at the Nakamura Clinic Conference Room in Union City on Wednesday, March 21st from 6 to 8 p.m. On Tuesday, April 3rd, from 6 to 8 p.m., Dr. Naveen Palbati, Emergency Medicine and Wound Care Specialist, will present Wound Care and the Latest Treatment Options. On Tuesday, April 3rd, from 6 to 8 p.m. at the Washington Township Medical Foundation Newark Clinic Conference Room, Dr. Jason Chu will present Respiratory Health and Lung Cancer Prevention and Detection. This seminar will also be presented at the Nakamura Clinic Conference Room in Union City on Tuesday, April 10th, from 6 to 8 p.m. On Thursday, April 5th, from 7 to 8 p.m., as part of the Diabetes Matters series, Dr. Amir Daska, podiatrist, will present Healthy Feet or Happy Feet. On Saturday, April 14th, from 10 a.m. to 2 p.m., Washington Hospital will host the 12th Annual Women's Health Conference. This event will feature topics such as female-specific stroke risk factors and prevention, an overview of improving your health and quality of life through surgery options, and tips for women to take action to discover a confident, healthy you. Dr. William Degoni, Medical Director for the Washington Women's Center, will provide an update on the Washington Women's Center. Fee to register is $25. To register, call 510-608-1301. The Washington Hospital Healthcare Foundation Report. The foundation will host the 33rd annual golf tournament at Castlewood Country Club on Thursday, May 3rd. Held in memory of longtime Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. To reserve your foursome or to sponsor the event, please call Washington Hospital Healthcare Foundation at 510-791-3428. Jo Shang Chang and the Fight Cancer Club at Milpitas High School recently made a heartfelt donation of craft flowers, Play-Doh, and handmade cards to the Infusion Center and the UCSF Washington Cancer Center. The flowers are decorating both the Infusion Center and the clinic, and the cards and Play-Doh gifts are given to patients. We appreciate these donations, says Director of the Oncology Program, Rochelle McCarthy. They are day brighteners for our patients. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District Board members attended the Fremont Education Foundation's Excellence in Education Gala on February 23rd and Abode Services Journey Home Breakfast on March 2nd. Washington on Wheels WOW Mobile Health Clinic. Washington on Wheels WOW Mobile Health Clinic is temporarily in Santa Rosa, California, helping support our North Bay neighbors who were devastated by October's wildfires. Santa Rosa Community Health serves 50,000 patients annually. The wildfires caused extensive fire, smoke, and water damage to its largest clinic, Vista Campus, and resulted in the loss of 56 patient exam rooms. The urgent need for temporary clinic space is the reason that WOW is now in Santa Rosa. Our mobile health clinic provides 2 temporary exam rooms. The mobile health clinic is expected to return to the district at the end of March. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's About WHHS was February's most viewed webpage with 35,252 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital's post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of February, Washington Hospital's cable channel 78, InHealth, captured new programming, including a health and wellness program titled Women's Heart Health and 2 mental health education series programs called Crisis Intervention and Understanding Anxiety Disorders. In addition, InHealth aired the January Citizens Bond Oversight Committee meeting and February's Board of Directors meeting. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
I'm very pleased to announce our March Employee of the Month. It is Sherry Harrington. She's a respiratory therapist in pulmonary rehab. She joined our staff as a respiratory care equipment technician who was studying to become a respiratory therapist. And once she completed her training, she joined our respiratory care department as a therapist. Her career at Washington began with a Bachelor of Arts degree in exercise physiology from California State University, Chico. While she was in college, she developed asthma, which led to an interest in pulmonary conditions. At Washington, she's had the opportunity to work as a respiratory therapist, a cardiac rehab exercise therapist, and her current role working with outpatients in the pulmonary rehab program. Sherry says working with outpatients is special. Our goal is to keep them out of the hospital. Our area may not be as dramatic as other areas of the hospital, but we impact the daily lives of our patients. She helps the patients set goals, and that may seem small to others, but are monumental to the patients themselves. One patient just wanted to get to the point where he could dance at his daughter's wedding, and we helped him do that, she said. She also gets to know patients through the Better Breathers for Life support group. Under her guidance, the support group has grown to more than 150 members, and that is a traveling group. I mean, they really get around. Director of Respiratory Care Services, Rebecca Mikolai, attributes this to Sherry's efforts. She gives of herself, and the patients respond to that. Many members have said they're loyal to the support group and to Washington Hospital because of Sherry, and she's the joy to be around. And I can attest to that. She is remarkable, and she does touch patients in a very personable and personal way. And she's very good at what she does. She's wonderful. We're lucky to have her here.
Well, thank you. Thank you, Nancy. Okay, we're going to move on to the Lien Report.
Okay, I'm going to introduce Nicholas Ludgy. He received his Bachelor of Science in Industrial Engineering as well as his Master's in Business Administration from the University of Pittsburgh. His professional career began at FedEx Ground, where he worked up the engineer ranks for 7 years. There he gained valuable experience in program management, data analysis, customer service, and process improvement. He came to Washington Hospital in 2011 as an industrial engineer and currently holds the position of Assistant Chief of Systems Operations and Management Support Services. In his current role, Mr. Ludgy oversees perioperative services, materials management, sterile processing, and the laundry department. He was part of the executive cohort Lien training and is Lien certified. With that, I'd like to hand the program over to Nicholas.
Thank you very much for the introduction, and thank you for having me. I always get excited when I can talk about some of the Lien work in my areas. Really excited about the work we've been doing in perioperative services, specifically in the elective neurosurgery. But once we kind of hone that in, it's something that we do plan to expand around the other service lines. But I wanted to set the stage, and I know sometimes you think of Lien, you think operational improvement, but really in just streamlining, making things better or faster for us and the workers. It's really revolved around the patient. You learn very early in Lien. Value is what the patient is willing to pay for. They don't want to wait. You know, what can we do to make their experience better? And hopefully through this presentation, you'll hear about some of the things and you'll understand some of the work we're doing in the operating room and the other areas in perioperative services to make this a better place for our patients. Like every other area that starts in a Lien journey, we start with a value stream map, and that's simply, let's figure out what's going on. You know, we always think we know what's going on in an area we work, but you really don't know until you go and observe. And there's a lot of eye-opening moments when you get to do that. So a value stream mapping, we get a small army together really to just learn about what's going on in the current state. So what we were looking at really in the perioperative services is from pre-op testing through the wills into the operating room for elective neuro cases. One of the things you do after you do all the observation though is you map out the process. And there you can really see visually, this is everything that we're doing. You note, what's the value added time? What's the waste? What's the wait time? And then you say, from this, where do we want to be in the future? And it might not be a year, it might be a few years down the road. And then you create a value stream map of where you want to be. Another thing you do is develop the A3T, and this is going to tell you, what your current condition is, and specifically from that future state map, what are those target conditions you want to hit down the road? For us, we'd like to increase our volume in neurosurgery by 10%. We'd like to reduce the lead time for pre-op visits by 30%. Reduce the patient time in pre-op holding by 20%, and increase those first case on start times from 25% to 50%. We also, there's an analysis portion today, A3T and proposed actions, and then what the implementation plan is, and that's the circled area here. And this is, how are we going to get there? What events are we going to have that will allow us to reach that future state? And here we identified 5 workshops to really help us tackle the current issues and get us to where we want to go. And the first workshop after every value stream is going to be a 5S. And the 5S stands for sort, set in order, shine, standardize, and sustain. And I know I think I was given my first report out after a 5S, and I was like, oh, it's like spring cleaning. And I was corrected very quickly. And it's similar. The problem with spring cleaning is you do it every spring. So the key about 5S and what a really important thing about it is that sustain piece. So not only do you get rid of everything you don't need, you organize it, you label it, everything has its place, and areas are standardized, there's a process to sustain it. So every single day, someone is maintaining that. So you never get to where you were. So it isn't spring cleaning because you only do it once. I wish I can translate that in my personal life a little better. But there's 3 areas really we focused on in the 5S, the equipment room, the core supply room, and the anesthesia workroom. And the biggest thing, and everything in a 5S, and I'll be honest, I've done several of them, you are exhausted. It really wears on you after the week, but there's always a really visual, remarkable improvement it gets everyone excited in that area. It really sets the stage for the other improvement work that's going to happen. So for this value stream, it was really that equipment room. You know, if you viewed someone trying to get a table out of that equipment room before, I think we measured it was over 2.5 minutes long. You had to hurdle another table, dodge a few, things on instrument or equipment on poles, and finally you can get to where you're going. So now you can see that picture. It's very organized. There's this parking space for everything, and I know when we tested it was well less than a minute, just from a few days of work in that area, and that's something that it got the staff excited. Where are we going to go next with it? And it's something we gave them something right away. And that's what that 5S does. It improves that area right away and gets people wanting to do a little more. From there, in September of last year, we focused on the first area, and that was the pre-op testing area. Our real goal here was to improve that patient experience. Simplify the information that we want. Let's not ask the same questions 50 times of those patients. Let's eliminate or reduce the amount of information we give them, the duplication of forms. And one big area I think for patients really was that they go to pre-op testing specifically in the 2500 building. Oh, they have to go get a lab? Okay, they're going to go downstairs to get the lab. They need chest x-ray? Oh, let's go over to imaging. So they had to go to the services. So we wanted to say, let's create a plan where we can bring the services to the patient. Let's make it better for that patient. And you could see a rough diagram that came out of that week of what that's going to look like. And that is the future of that, is we actually already met with an architect on, hopefully, in the near future, we can put that plan into place. For the staff actually that staff the pre-op testing, there's 2 different areas we do pre-op testing, and so they actually run back and forth depending on the type of procedure they're getting. So this will be a win for the staff as well, as there's one area for the patients and one area we have to staff. So some of the measurements that we were able to see improvement on, one was the actual lead time it takes to go through pre-op testing. One thing we realized is that there was a lot of chest x-rays being done during the pre-op testing that wasn't necessarily the standard anymore for all the patients. So now the standard was updated, and we went from 100 minutes down to 66 minutes for those patients. So right there's an improvement to a patient not getting something done that they didn't need, and they can get through that pre-op testing process much quicker. Another measurement that we had was the amount of patients going for elective neurosurgeries that were not going to, actually all I think elective surgeries, actually not just neuro, that were seeing, having a pre-op testing visit or a phone call. So the goal for the operating room is we want to see every patient before they come in the doors. So we don't want to be surprised when they come into pre-op holding. Maybe there's some elevated levels or something that you have to cancel a case that day because they didn't have a pre-op testing and we weren't flagged for something wrong earlier in the process. So the goal is, let's see all those patients. We want to touch every patient coming into the OR prior. So when we did this, the baseline was 27% of the elective cases were not going through pre-op testing. So now we changed the way we work. We're doing more phone calls. In December, that dropped to 10%. And our goal really is 0% of patients that are coming through for elective surgery are not touched by one of our staff. In the future, one of the results of this is we hope to have less canceled cases, really on that same day of surgery. So right now, we started at 2%. It went up to 3% in December, but then we've kind of structured the way we do the phone calls. We're scheduling those now instead of them just calling, so we're going to be more successful in the future, and hopefully that's going to result in those less cancellations that, close to surgery, which then also cancellation means, we have the staff are ready to go, and then there's no patient for the room. So our workshop 3, we wanted to really attack the scheduling piece. And specifically for neuro, these are very complex cases. And oftentimes, the OR had to revisit that schedule several times as they learned more information about the case. So we really wanted to focus on standardizing a form that can be used to have a more complete schedule initially when they do the schedule. So here's an example of the neurosurgery scheduling form. They had one. We bolstered it up a little bit with some of the information that the OR would like to know about that case. So the physicians are actually filling this out, and there's actually a place for the physician to sign. This gets scanned into Epic and actually is a physician order. And when this gets passed over to Epic, the OR schedulers actually can view this in case they needed to reference it for anything. There's actually current work done to get this built into Epic, so there is no more form to further streamline the process. Another area really was focusing on the standard work. There's not a lot of people that actually do the scheduling on the clinic side or the perioperative service side. But you'd be surprised by the variation that they learned about and how differently each of them do it when they got to talking. So really we want to develop that standard work that everyone schedules the same way, and there's some consistency in that process. And the last thing, we worked really about Epic technology improvements and what can we do in Epic. One thing was getting that form as we're moving forward, getting that built into Epic so that we're not using that old paper, getting the schedulers to see this information when they need to reference it. And that's work that is currently happening right now. The fourth workshop that occurred back in January was preference cards. And I think if you ask every OR director, they're like, that's a problem in my area. Everyone I've talked to, it's always the same issue. It's a real effort to keep them accurate. For anyone who doesn't know what a preference card is, it really is the recipe for a case. It's going to give you everything you need to know. It's going to give you the instrumentation, what supplies need to be pulled, what table you need, what positioning of the patient does that physician prefer. And every physician should have a preference card for every case they do. So as we worked through this process, we realized that our current preference cards aren't even used. Most of the time, it's really tribal knowledge. They know the surgeon, they've worked with them. The problem with tribal knowledge is when someone leaves, someone has to really learn it. So we really wanted to work on getting these right and accurate and getting the staff to really use that preference card and get used to it. So some of the results that we did, we decreased the time to set up for the first case and for the time it takes for the OR to pull supplies. And that was by doing some rearranging of the way the supplies showed up on the preference card so the OR sees, oh, these are the supplies I have to pull, as opposed to coming from a sterile processing department, which also pulls supplies for the case. We created standard work for using preference cards on every case. So we really wanted the staff to know how to use the preference cards, what to look at. They're not used to working with the preference cards. We created standard work for updating preference cards and implementing this in the post-surgical debrief. And you can see this is an example of a form that we created. That's the edits that they make during the case are going to go on this form. And during the debrief, the nurse is going to say, hey, I wrote this down. Would you like me to change this on your preference card? And I saw one of our physicians who was part of this team. I saw him a few weeks after, just passing in the hall, and he was glowing. He's like, oh, the nurses they're making us do the debrief, and he was really pumped up and excited about it, and excited to get these preference cards, more accurate. We created standard work for documentation and documentation for picking items for a case as well. And we established a system for decreasing the defects. And one thing that sterile processing measures, and sometimes there's everything you need and a whole lot more on a preference card. And what that happens is supplies go up, then they go right back down to sterile processing. So a lot of work for sterile processing to pull it and to return it. So one of the things we measure is what is the percentage of items that we send to the operating room that we have to put back in our inventory. I think December was up around 27%. Usually we're closer to 20%. February was 11%. The best month that they've ever had on the percentage of items that they've had to return. And from talking to sterile processing, those preference cards are locked down for neurosurgery. That right portion of this that's not circled, that actually gets funneled back down to sterile processing with the extra supplies, so they know what case that came from, and they filter that information back up to the OR to review it. So this communication is happening, and the questioning, do we need this? So it's a lot of effort, but it's necessary to keep these updated and continue to be more accurate. And here's the staff really working at the standard work and using that preference card. There's one more workshop we have. It's about a week and a half away. We had a planning call earlier today, and it's room turnover and setup. So room turnover, we measure it as the wheels out from one case, the time it takes from the wheels out to one case to the wheels in for the next case. So, and that initial setup as well for a case. So when something gets off schedule in the beginning, it has a domino effect. The rest of the day can throw everything off. So we really want to focus on tightening up. Everyone has their responsibilities and is accountable, and we can make sure we're doing everything as efficient as possible. We want to make sure the right equipment will be available and functioning, because there are times you go in, oh, the microscope isn't working. Well, we should probably be checking that before to make sure that they don't come into a case that way. Or when the staff come in at 6:30 in the morning for a 7:30 case, we want that room to be ready, the night before, not them having to scramble to get that ready. Really make it easier on everyone involved. We want to integrate and refine some Epic tools in all phases of the process. One thing that we've added recently that'll help is a room ready flag. Right now, the turnover, trying to dissect what's going on. Is it getting the room ready, or is it getting the patient in? So this flag will actually help us. What's taking a lot of time, and where can we focus our efforts on? Also, one of the goals is that the circulating nurse and the tech will have everything they need to do a full, complete setup. Nothing missing, no instrumentation missing. That's creates a lot of havoc, unhappy surgeon, delays. So really, this will be an exciting Kaizen workshop, and it will conclude the workshops that we had planned. But the work doesn't stop after we're done with the Kaizen. It's really, this last Kaizen, it's really taking it and continuing to work on it, improving on the base that we formed in these 5 workshops. So that's all I had on the update of the work we've been doing in perioperative services. I'd be happy to answer any questions.
Any questions? No, very impressive. Nick, very, very good. I can't imagine there's very many hospitals that are doing what we're doing.
A handful.
Handful.
Yeah.
And I think this is the kind of work that makes us one of 100 best in the United States and going to keep us right up there at the top. So.
And somebody with Nick's background and skills is right out of central casting for this. He has the knowledge, and he's applying it, and everybody benefits.
Yeah. Win-win-win.
Win-win-win.
Yeah.
And we'll just continue to get better and better as it becomes more ingrained as well. So it's exciting. Thank you very much.
Okay. Thank you. Thank you. Okay. Ed, we're getting close to the finish line, huh?
Oh, boy. Yes, sir.
So, yes, we are, it's March, and June is just around the corner. So we're continuing on time. Again, you'll see in this presentation a lot of work going on the outside of the facility, and you'll see the inside is getting in a pretty finished state. Again, I'd say the biggest concern right now is we still have our external kitchens to go, still outside in the way of the pathway into the new hospital. We were supposed to have OSHPOD in today for a final sign-off. Now they're coming tomorrow. And hopefully that's it. I was on the phone today with Sacramento to say, we got to go. So
this is something the board needs to be very clearly aware of. When they centralized all the inspection functions in Sacramento, their ability to inspect on a timely basis seems to have evaporated. And it is a very serious concern that they could come late for the Morris Hyman Pavilion and that we wouldn't be able to open when we plan to. And we're going to start working now with them to do everything we can to prevent that from happening. When we visited Lucille Salter Packard Children's Hospital last week, I asked Chris Dawes, did they have a problem with that opening the new children's hospital? And he said initially that they were told there would be a 3-month delay. So I think we have to prepare ourselves, and we have to do everything humanly possible to try and get them here on time. Yeah. But it is a reality, and it's nothing that Ed can control.
Right.
So here's the slides. This is a shot of one of the radiology rooms in the emergency department. So you can see flooring going in here. We don't have the X-ray equipment and the CT scanners installed yet, but that's coming up in the coming month. This doesn't give you a great view of it, but that white sheet that's in there is the new white terrazzo floors. So they're in 3/4 of the main lobby now, and they'll be finishing that up. It's also on the main elevator lobbies on the 2nd and 3rd floor as well. This gives you a look at one of the critical care units, and it gives you a sense of one of the things to identify the different units is by shades of color. So this one is a little bit different. Usually you'll see we've shown, I think, purple and blue in other presentations. This gives you a look at, the color will be used as wayfinding or identification of units as part of the program. We have a couple of pictures of this. People wonder what this is. This is something that's called a wand door, and so it's shown here, and we have another picture in a minute, closing around the atrium. So this is tied into the fire alarm, and if there would be a fire alarm or smoke detectors that go in the area, this encloses the atrium, so it basically closes it off. If there was fire there, it keeps it from spreading to other areas of the hospital and creating that chimney effect of the atrium. This is a staff lounge on the 2nd floor. We've got several nicely sized staff lounges, and they all have very nice access via windows and natural light to the outside. So they're all pretty attractive. This gives you another shot of the idea of the wand doors in the atrium. You've probably noticed the steel starting to go up. This is the canopy in front of the emergency department, again, exterior, work on the exterior, next the roadways, the parking spots, driveways in front of the ED. This shows you that the moat's starting to get finished. So this is concrete going in the moat covers, and we'll have this look almost sidewalk-like around the entire building. This is one of the staircases in the northeastern actually it's southeast corner of the building, so mislabeled there. And this is, you can see the paving starting, or getting the compact in the soil around the back of the Hyman Pavilion, so that roadway between the garage and the pavilion will be completed and large enough for large vehicles to go through there. The location for the fire engine in the event of fires and things are in this space back here. So this is all moving towards completion as well. This gives you a little bit more intimate look at the loading dock from what you've seen before. So this is the back section. The wall that you see there is the old loading dock, and it's being moved forward, about doubling the size of our loading dock facilities. And the space behind there, back in here, is the ceiling for the connecting corridor that will be running behind the loading dock. This gives you a little bit better shot. So the corridor coming here, running through here, over here, and into the building. So that's the update. Is there any questions I can take?
Any questions? No, thank you, Ed. Thank you very much.
So close.
And
It's so exciting.
Yeah, yeah. Okay, we are now going to move to the quality report. Mary?
Thank you. Good evening. Tonight I have a report that I'd like to give an update on our American College of Surgeons National Surgical Quality Improvement Program. We'd like to bring this data to you on an annual basis, and this year I think we can really see some true success out of the surgery department and their outcomes that are pretty exciting. To start off with, what is NSQIP? What's the background on this? And this is a National Surgical Quality Improvement Program. It's based on and built by the American College of Surgeons. They really got together and decided, what's a way to look at our data comprehensively? Can we use it to make improvements, compare it nationally to other benchmarks? And they take the group of patients that are all reported nationally, use risk-adjusted data, benchmark it, and eventually Joint Commission started looking at this and thought, this is a really good way to measure national improvements and areas for opportunity in how we do surgery. And so Joint Commission worked with CMS and soon decided that this database was vigorous and evidence-based well enough to where they actually have recently made it a requirement to participate in, and is a way of looking at these national outcomes. As the years have gone on with this database, you can see there's quite a few hospitals that participate in the nation. About 704 participate in NSQIP worldwide. The historical timeline on it is it developed as well as early as the 1980s. In 1985, the VA got involved in it and then eventually started to collaborate with the American College of Surgeons. And about early 2000s, everybody started looking at this and thinking this may be something that we even want to take to community hospitals. Let's go beyond the VA. And in 2013, we decided to do the same and started to participate in the registry because we wanted to use it as an opportunity to take evidence-based guidelines to improve surgical outcomes. And like I mentioned before, about a year after that, it was actually CMS who came in and said, this is something that we really recommend, and they're even willing to give some sort of incentive payments, things like this, to participate in a general surgical database. This is the best way of putting this. So specifically here, when we had the discussions about implementing it, we decided, first and foremost, we want to use this data to improve patient benefits. We want to make sure we're always following the best, most accurate evidence-based care. Looking at patient satisfaction because we've involved them in the process of using this data, and making sure that if there are any issues around mortality or morbidity, if patients are having complications, we want to be able to look at that. Surgeons also benefit from this a great deal. It's a great way for them to get their data returned back to them, and they can use it for their own peer-to-peer process improvements in surgery. And overall in the hospital, it's a great source for us to take this data, use it transparently, share it throughout the hospital to make our improvements. There are different levels of NSQIP that you can participate in. We have progressed to the point where we are currently participating in the maximum level of this database. We've been doing that since 2015. And in doing that, we were able to expand the list of procedures that we want to be looking at. And we also dedicated a full person in quality who can really take on this database, apply the knowledge from it, put in all the data. It's actually very comprehensive. It requires some training and a process in your quality department that I think in the end pays off very well because you really get some good insight to what's going on in surgery in your hospital. The components of our quality reporting really follow the patient through the entire care process. This is another thing I really like about this database. You can follow your patient through the preoperative data experience that they have. What data and labs are you getting on them? What's the clinical picture? All this is collected prior to the patient even going to the OR. In the OR, we look at certain metrics that relate to what happens in the OR. Is there a complication? Any sort of data that goes through there and is discussed by the surgeons is looked at very specifically related to what's going on in the actual OR. Postoperative is another great feature of the database that we can follow. We follow all patient outcomes. As I said before, it's really looking at, are there any complications? If there are, what could we have done to prevent them? What can the peer review process do to make improvements and make sure that we can assure that these things don't happen in the future? Did the patient get a surgical site infection? Did they even develop urinary tract infection? These are the sort of things that we can utilize from the database. We do follow these patients for up to 30 days. And you can see the patient population we're following is fairly comprehensive since about 2015. It's not general, just general or vascular surgery, which is initially what we were doing. When we upped it and looked at a greater deal of procedures, we've covered everything from cardiac, gynecology, neurology, orthopedic, thoracic, urological, and even some plastic procedures. So very comprehensive list that we look at. And again, getting into the post-op follow-up. This is a key point to this database that makes it a little unique to some other databases in the fact that after the patient has gone through their surgical procedure, our quality department looks at the notes, looks at what their hospital stay was, but that doesn't always give you the whole picture. So they ask you to take a step beyond and really look at what was the experience the patient had after the surgery, and can we make contact with the patient and call them up, see what their outcomes are, even speak to the surgeon afterwards in their practice. And we do all those things and have been able to get some great data from that. As I said, it takes a strong clinical background to participate in this database. And right now, what we are and what the recommendation is to follow is before somebody even starts abstracting in this database, they should have about 8 weeks of really vigorous web-based staff training. When we have an employee who does this, they go into their own office, they listen, they're fully involved in having an interactive web-based training where they can meet other people who are in the same position, speak to surgeons. It's a pretty comprehensive program. And in order to be able to move on to abstracting from the database, you have to pass a competency evaluation test. And we also have another process that we do here closely where our quality coordinators that abstract this data actually audit one another. We have two. We have a per diem that covers, and they work very closely together and do independent audit. So I feel very much so that this data is valid. The way that and the structure that we use to flow this data through is, of course, the data comes from inpatient, outpatient units. This is where the operation occurs, and we then take that and follow up for the 30 days. And then it goes to the surgeon champion, which is our quality advisor, Dr. Pipkin. He looks at this data very closely. There's a lot of discussions about it in quality. We send things out for peer review, and after we do that, and then the data, of course, goes into the database, and we get our reports and our executive summaries. And this gives us the opportunity to then move it on to the chair of surgery so that they can look at it and decide, what are the appropriate areas that we can utilize this information in the surgery department. And we've taken executive summaries and taken them to general surgery or any surgical section that could benefit from this knowledge. We want to actually continue to do that more moving forward. Again, you can collect all this data-rich data. You can dedicate an entire FTE to it. But if you're data-rich and action-poor, that's not where you want to be, right? So our next step is, what are we going to do with it? Because we want to make sure that we're moving towards improvements to make changes in outcomes. So our latest data is focused on a few different things. First and foremost, mortality. Looking at, did a patient have a procedure, and then within 30 days start to have a decline and actually pass after a surgical procedure. And we have done very well with this. In fact, NSQIP has a star system and that they assign to each one of these. And for mortality, we have received exemplary status. And this is a pretty significant status to obtain seen from NSQIP. Basically what it means is that you're in the top 10% of hospitals with the lowest mortality rate. So again, you saw 700 hospitals participating. So to make it to the top 10% with mortality is a real reflection of the surgical department and the entire management team of that patient really having a great outcome. This is based on fiscal 2017 data. And that is based on our observed rate of less than 1%. You have 0.9% of mortality. That's a huge achievement when they expected us to be closer to 1.8 mortality. It's the same thing with complications. We received the same exemplary status on our patients who have this whole list of procedures and every service line basically, and still we are in the top 10% of patients with lowest complications. And this is a great success. These are monitored for 30 days afterwards. And like I said, we don't lose the patient after discharge. We follow up with the surgeon. We follow up with his practice. We have conversations with the patients. And we even send out letters to the patients if we can't reach them. And here we have about 3.4% complication rate. That's significantly lower from the expected of 6.1 for our type of patients in our type of facilities. Readmissions is another factor that NSQIP really wants to look at closely. How many of your patients come back with an unintended readmission within 30 days of having a surgical procedure? We have a much lower rate in the fact that only 4.1% of ours do. And even when you risk adjust it, it's 5%. We're closer to expected to about 5.7 on this. So we're doing very well with readmissions. And we'll get into the specific service lines and look more into that in a minute. Unplanned returns to the OR. This is something that in quality in the surgery department is highly surveyed, it's highly scrutinized. If a patient has to go back to the OR and you didn't think they were going to, that we take very seriously here. It goes through peer review. There's serious discussion with these cases. And again, you can see a great outcome of a much lower rate of unplanned return trips to the OR, actually 1.4% of those when the expected rate would have been closer to 2.5. Another great outcome. Don't want to expose a patient. You want to lower their risk to ever having to go back to the OR and have any invasive procedure, and we've had a lot of success with that. Respiratory complications is another issue that tends to happen. It's a risk factor for anybody who has surgery, especially elderly people or people with high comorbidities. They can tend to have this risk of getting a respiratory complication, which would be things like pneumonia or having to end up on a ventilator. Things of this nature are followed for about 30 days. And again, you can see observed rate is less than 1%. Patients ended up with this complication. And unplanned intubations are another really key thing that we want to look at, because when only 0.4% of your patients end up with an unplanned intubation, you save that patient from a lot of other things, because as we all know, intubation can lead to pneumonia, lead to longer time being in critical care, lead to further complications. And so to have the patient have such a good outcome that they don't end up intubated is great. 0.4% is great on that. We also received another exemplary status. This relates to infection prevention. In general, hospitals and the CMS and everybody is looking very closely at infection prevention, because as we know, in a hospital, there's a lot of risk factors that can potentially lead to developing an infection. So to achieve exemplary status in this, meaning that once again, we're within the top 10% of hospitals with lowest surgical site infection rates, and ours were actually at less than 1%. And if you risk adjust this, meaning looking closer at patients and how sick they were and what were expected of this patient during having a procedure like this, only 1.1% of those patients developed surgical site infections. And that's out of 557 sampled cases. I'm very happy to see that. And moving into general surgery, another thing I like about NSQIP is they break it out per the surgical groups. So that's very good for those groups because they can see their own data specifically to their practice. General surgery received exemplary status. Again, with this, especially related to mortality, in the fiscal year 2017, out of 153 sampled cases, there is actually a 0% mortality rate for non-risk adjusted. When you move into risk adjusted, closer to 1.8, but still incredibly small amount of patients who do not survive within 30 days of procedure. Renal failure, it's another thing. The kidneys tend to do very well. We don't have a lot of kidney complications after surgery. Was very happy to see that. Urinary tract infections, and again, readmission, you can see for general surgery, all have great outcomes. Cardiac surgery is another area that NSQIP has provided us with exemplary status on. And these are based on a few indicators that we look at pretty closely, which is, of course, mortality, renal failure. How did the patient's kidneys do after surgery? How did we monitor it? What interventions did we take? Did they develop urinary tract infection? These sort of things. Also, we've continued to see very low rates of mortality at about 5.6%. Again, cardiac surgery has a very low surgical site infection, which especially is a good success because, as you know, in that procedure, they have a wire in their chest, and that's considered an implant. Also can increase your complications for surgical site infections. So they're watched very closely. They're actually watched for about 90 days. And so to see those at such a low rate is very exciting news. I think we've heard a lot of, even a little bit earlier tonight, about what we can accomplish here with our orthopedic surgeries is just really a great success. Again, they gave us exemplary status for this. These patients don't get UTIs here because their process is so standardized that the second that catheter is not necessary for the patient, it comes out. And they're very particular about that, which is great because then the patient doesn't develop urinary tract infection after having their total knee, which can lead to other complications. Very few people come back after having their knee surgeries here. That's what you're looking at with the readmission rate, 0.8%. In fact, what this doesn't reflect also is that majority of these patients are actually going home when they can with home health, and that's great. So they're not having to, unless it's medically necessary, transition into a SNF. So exemplary status there is not a surprise to any of us, I know, but another good thing to celebrate. Same thing applies with our total hip replacement. They give us another exemplary status for this based on morbidity and complications that happen to a patient after they have this procedure. This was based on 97 sampled cases, and as you know, we do a far greater volume than that. NSQIP does sampling, and I can tell you that I have seen the overall total with these patients, and we followed them very closely for 30 days. And even in the big group of volume that we do, this is very reflective of their outcomes for total knees. Where we would like to go with this database in the future is we really want to continue to use NSQIP as a source of keeping our evidence-based practice. That's what's great about participating in national databases. They give you data that is current, and it comes from surgeons. It's shared with surgeons. I think it's the evidence and the literature they use is very reputable, and it sort of helps us guide what improvements we want to make, even right down to the bedside, to education of clinical staff, and reducing our adverse outcomes even furthermore. We do report this data to the Centers of Medicare and Medicaid Services, otherwise known as CMS, and I think that I don't foresee any problems because of we've made so much exemplary status. And the next, not only is this a celebration of great outcomes in practice from surgeons here, it is the entire team, right? This takes an entire team to make sure this happens. There's a multidisciplinary team too, right down to how clean you keep that room, to how fast you take out that catheter, to how you communicate with your next shift that's getting that patient, and to how the working relationship is in the OR. that's really what this is a reflection of, because without those moving components together, you would not be able to have outcomes like that. And so I'd like to move it further into a stage where the surgeons can really utilize this knowledge along with the rest of the hospital. Thank you. Any questions?
Well, thank you, Mary. Any questions, anybody?
Thank you.
Thank you very much. Thank you. All right, we're going to go to the finance report, look at our numbers.
Good evening. Tonight we'll be looking at Washington Hospital's operational and financial results for January. Move right into our operating indicators. Average daily census for the month was 3.4 below budget at 185.6. We had 1,204 admissions. That was about 21 above the budget. Patient days, however, were 107 below the budget at 5,753. We have been seeing lower lengths of stay all year, so that's not necessarily a bad thing. Outpatient observation equivalent days for the month were 69 below budget at 128. And our average length of stay, this is based on discharges, a little bit lower than budget at 4.9. Looking at utilization, case mix index for the month was lower than we had seen for a while at 1.424. We had 134 deliveries, about 3 below budget, pretty close. Surgical cases were 21 below budget at 381. That includes our joint replacement cases that were 10 above budget at 163. That's pretty high volume for those guys in a month. Neurosurgical cases were 11 below budget at 21. We had 7 cardiac surgeries in January, just 1 below the budget. And our cath lab procedures for the month came in 32 below budget at 308. Outpatient visits for January were 429 above the budget at 7,292. It's nice to see those volumes coming back in the outpatient arena. And our emergency room was busy in January, just a little shy of 5,000 visits, about 289 above the budget. Quick look at the cath lab activity for the month. Peripheral vascular and cardiac procedures were neck and neck in dominating the activity, followed by our non-vascular interventional radiology procedures and our neurointerventional radiology procedures. Quick look at productivity. Productive FTEs for the month came in 92.5 below the budget at 1,294.7. We had 180.7 non-productive full-time equivalents in January, giving us total FTEs that were 123 below the budget at 1,475.4. Our full-time equivalents per adjusted occupied bed, which is a measure of our productivity, came in 0.37 below the budget at 6.05. So, a little bit lower activity in the month. And management did a great job of adjusting to that activity. And we'll see the benefits of that when we get into the expenses. It really makes a difference. Moving into the financials, first we'll look at our Governmental Accounting Standards Board presentation. This is, for those who aren't familiar with this, the presentation we use for our audited financials. Total patient revenue for the month was a little bit over $8.3 million below the budget at $181,989,000. Although we got a lot of help from our contractuals this month at 75.72%. A couple things driving that. We are collecting better on our accounts, particularly in the PPO bucket. Those collection rates are going up. But we also had some cost report appeal recoveries from 1999, 2002, and 2003. So we appeal those things, and we fight, and we fight, and we fight. We do not give up. We keep going for years if needed, and it reaps its rewards. So that amounted to about $240,000. We also received our annual supplemental payment for Medi-Cal outpatient activity. Medi-Cal, a long time ago, there was a law called AB 915 This has been going on for years. We file for this every year. This year, that supplemental payment to help us with the cost of seeing those patients amounted to $1 million. So that's really helpful. So we actually, although we were lower in our gross revenue, end up with net operating revenue for the month $624,000 above the budget at $48,689,000. I do want to note that that amount includes a $4.1 million donation that came from the foundation annual meeting, and that includes money from several sources, including the foundation, our service league, Washington Township Employees Association, to help fund critically needed equipment and to help us outfit the Morris Hyman Critical Care Pavilion. So thank you to all those organizations. Your hard work goes beyond just helping our patients, and that help is critical to our success. So thank you to those organizations for that. It was extraordinary. Operating expenses for August came in $863,000 below the budget. That includes salaries and wages that were $1.1 million below the budget. So you see the impact of that FTE control. That is a big lever to pull, and it really matters when we get to the finances. Benefits for the month were $200,000 below budget. We are starting to see those high healthcare costs that we've been seeing all year starting to level off, and it looks like that trend's going to continue in February. Purchase services and pro fees were about $300,000 over budget. That was driven by our dialysis service fees, as we've spoken in past months. We had hoped to have brought that service back in-house by now. Looks like that's going to happen early next fiscal year. So we're going to see that variance the rest of the year. Also, we paid some fees to Toyon, who is the firm we use to help us with those cost report appeals. And they get paid when we do. So those were a little tough to time when those are going to happen, as you could see with the ages of those cost reports. Also had some higher than expected recruitment fees in there. Provision for bad debt and charity also offset the positive variances. That was over budget about $519,000. And you know, we've been talking about that. Those numbers continue to trend higher. But we ended January with a very positive bottom line, almost $1.5 million above the budget at $6,374,000. Non-operating income for the month came in $964,000 below the budget at $796,000. That includes an unrealized loss in our investments of $829,000, and as yields on bonds continue to go up and interest rates move up, we're going to see downward pressure on the value of those our fixed income security portfolio. But we end the month with a very solid bottom line of $7,170,000, about $523,000 more than we expected for the month. Take a quick look at our Financial Accounting Standards Board presentation. This is a representation of how the financial markets might adjust our GASB presentation to look at us. No change in our operating bottom line, but FASB does not recognize our unrealized loss on our investments or our property tax income that supports the maintenance of our general obligation bonds. So we end up with non-operating income from a FASB perspective of about $269,000 and a total bottom line a little over $1.3 million above the budget at $6.6 million. So are there any questions on January's financial results?
No questions, thank you.
Can't question good results.
Yeah.
Okay.
Go ahead, Nancy.
We'll start with the preliminary report for February. Our gross revenue of $159.4 million for February was below budget by $13.2 million. That's a 7.7% negative variance. And although gross revenue was below budget by that amount, Our preliminary estimate on net patient revenue is above budget by $358,000. And this is due to a favorable payer mix and a change in our estimated reserves. Inpatient gross revenue was $12.4 million below budget, and outpatient was $835,000 below budget. The major drivers of the revenue variance are the inpatient days coming in below budget by 459 days. Observation days are below budget by 72 days, and that's a good number. The lower patient days drove the ancillary services revenue below budget by about 6.5%, and room and board revenue below budget by $4.4 million, or 11.9%. The cath lab procedures came in below budget by 56 cases, and that drove its revenue down by $2.4 million. The inpatient surgical volume was also below budget by 4.7%, driving our surgical services revenue down by $620,000. In terms of key census statistics, the average length of stay of 4.64 was below budget of 5.07. That is an exceptionally low average length of stay. It was 15% shorter than February a year ago. Outpatient observation days, as I mentioned previously, were 72 days lower than the budget. The outpatient observation days were lower than February a year ago by 49. Our average daily census of 170.3 came in below the budget. We had budgeted 186.6 days. Our admissions are below budget by 1.5%, so nowhere near as great a variance as in the number of days stayed. Leads back to my comment of the average length of stay being extremely low. Our admissions for the month were 9 less than February a year ago. The patient days of 4,767 are below budget by 459 days, or 8.8%. Again, the low length of stay. Our surgical cases in February were 365 above budget. I'm sorry, they numbered 365. They were above budget by 21. I apologize for that. And there were 20 more of them than there were February a year ago. The inpatient surgeries were 13 below budget. The outpatient surgeries were 34 above budget. The increase in cases came predominantly from joint replacement. They had 17 more cases than we had budgeted. The general surgical cases were also above budget by 17. Cardiac surgical cases came in below budget by 3 cases, and neurosurgical cases were below budget by 10. Cath lab procedures for February were 56 below the budget and 65 fewer than February a year ago. The inpatient cath lab procedures of 155 came in below budget by 16, and the outpatient cath lab procedures were below budget by 40. Cardiac procedures in the cath lab were below budget by 40, as I mentioned, and non-vascular interventional radiology procedures were below budget by 15. Neurointerventional radiology procedures were below budget by 3, and peripheral vascular procedures came in above budget by 2. In terms of deliveries for February, we had 143. We came in above budget by 11. That's an 8.3% positive variance. And there were 23 more deliveries here in February than there were a year ago. Non-emergency outpatient visits of 6,902 were above budget by 350. That's a 5.3% positive variance. They were also above February a year ago by 580, which is a nice variance. Lab visits came in above budget by 315. Cardiac rehab visits were above budget by 74. And our x-ray visits were below budget by 21. In terms of our productivity indicators, productive FTEs were below budget by 126.4. That's a 9.1% variance. They came in at 1,258.7. So management was flexing down with the decrease in activity appropriately, which helps with financial results. Non-productive FTEs came in above budget by 3.8 at 186.7. The total FTEs of 1,445.4 were below budget by 122.6. That's a 7.8% variance. Our total FTEs per adjusted occupied bed of 6.38 were below the budget by 0.05. Our other operational statistics include activity at the outpatient surgery center. They had 413 cases in February, 67 cases below budget. The clinic visits of 3,286 were below budget by 477 cases for the month of February, and 618 below February a year ago. Payer mix was very favorable in February, which also helps with the financial results. Government-sponsored patients' revenue made up 69.2% of total gross revenue. We had budgeted 72.9%, and since both government programs pay below what it costs us to provide the service, this is a variance that's positive for us. The HMO revenue was 2.9% of gross revenue, which was at the budget. The PPO revenue was 25.7% of gross revenue, which was above the budget, which called for 22.5%. And that's a significant help with the financial results. Private pay revenue was 2.2% of gross revenue compared to a budget of 1.7%. So we're continuing in the trend of seeing more private pay. Our key financial statistics include days cash on hand for February of 175 days, up 2 days from last month. Days of gross revenue and accounts receivable were 52. That's got to be one of the lowest you've seen. And as Chris had mentioned earlier in his report, they were doing extremely well in collections, and the days in accounts receivable are a direct reflection of that. There was $619,000 in charity care applications pending or approved in February.
Thank you, Nancy. Any questions? All right, we're going to move on to the action items. Dr. Eapen, Action A.
Mr. President, in accordance with the district law policies and procedures, I move that the board authorize the chief executive officer to enter into necessary contracts to proceed with the purchase of the Medtronic's external pacemaker generators for an amount not to exceed $119,000.
Thank you. Have a second for that?
Second.
Okay, thank you. Nancy?
This is another case of planned obsolescence.
Yeah.
In May of 2014, Medtronic discontinued service and support of all the external pacemakers we own. So currently we own 18 single and 11 dual chamber generators, and moving forward we wish to purchase only the dual chamber generators to simplify training and distribution of devices. And so this is something that we need to move forward with. We have negotiated a discount of 20% and will receive, with trade-in, another 20% discount. The company says it will support these new devices for the next 7 years. This is a purchase that is included in the fixed asset capital budget.
Thank you. Steve?
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Okay, motion passes. Item B.
In accordance with the district law policies and procedures, I move that the board authorize the chief executive officer to enter into necessary contracts and proceed with the purchase of end-titled CO2 modules in an amount not to exceed $42,000.
Thank you. May I have a second?
Second.
Thank you. Nancy?
The end-tidal CO2 is the partial pressure or maximal concentration of carbon dioxide at the end of an exhaled breath, which is expressed as a percentage of CO2. Capnography is the measurement of exhaled carbon dioxide or CO2 levels. This technology is also referred to as end-tidal CO2 monitoring. A capnometer monitors the level of exhaled carbon dioxide to assess a patient's ventilator status. CO2 monitoring is considered to be the parameter that best represents the adequacy of ventilation. It is a much better monitor of respiration than pulse oximetry. Patient who is hypoventilating will trigger an apnea or elevated exhaled CO2 level alarm with this new equipment. And it gives the physicians precious time to intervene before there is a full-blown respiratory arrest. The PACU is the one place in the hospital where severe respiratory depression is an expected daily event. So we wish to purchase 8 of the Philips modules for the PACU, not to exceed $42,000, and this was included in the fixed asset capital budget.
Okay. Thank you.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Thank you. That motion passes. Item C.
Mr. President, in accordance with the district law policies and procedures, I move that the board authorize the chief executive officer to enter into necessary contracts to proceed with the purchase of 4 giraffe warmers for the special care nursery for a total amount not to exceed $90,933.05.
Thank you. Have a second?
Second.
Thank you. Nancy?
The total cost of the warmers is indeed $90,933.05. We're very precise here. These are for our special care nursery. They'll be used to replace warmers that are currently outdated. The giraffe warmer helps provide a nurturing, life-sustaining environment that fosters growth. The warmers are used also for resuscitation of newborn babies after delivery. The funds to purchase these giraffe warmers will be coming from our foundation, and what I am requesting the board's permission to do is to take the money from the foundation and purchase the giraffe warmers.
Very well. Very good. D.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Epen.
Aye.
Director Nicholson.
Aye.
Director Danielson.
On behalf of all the newborn babies, I want to thank the foundation.
We want them cozy.
Yeah, nice and cozy. Okay, any more items for the open session? We now are going to adjourn to the closed session. Thank you. Okay, we are going to reconvene the open session and announce that there were no reportable actions taken during the closed session. With that, this meeting is adjourned.